Addressing mental health issues is a luxury. It's a thought-provoking statement that stirs up connotations of wealth and necessity. But in order to address mental health, we must first put a definition to the term. As defined by the World Health Organization, it is a state of well-being in which every individual realizes their own potential, can cope with the normal stresses of life, can work productively and fruitfully, and is able to make a contribution to their community. It is clear from the WHO's definition of health as a whole that mental health is integral to a person's overall well-being. So mental health is more than the absence of mental disorders and is determined by a range of socioeconomic, biological, and environmental factors. There are various forms and types of mental health disorders. Firstly, depression, which is characterized by sadness, loss of interest, feelings of guilt or low self-worth. Anxiety disorders, where the feelings of worry and fear are constant and overwhelming and can in turn become disabling. Bipolar disorder, a brain disorder that causes unusual shifts in mood, energy and activity levels and the ability to carry out day-to-day tasks. PTSD, a disorder that develops in some people who have experienced a shocking, traumatic or dangerous event. Schizophrenia, where people have changes in behavior and other symptoms such as delusions and hallucinations. Anorexia nervosa, characterized by the inability to maintain a minimally normal weight, relentless dietary habits that prevent weight gain, and a disturbance in the way in which body weight and shape are perceived. And OCD, where a person has uncontrollable reoccurring thoughts and behaviors that they feel the urge to repeat over and over. In 2004, mental disorders accounted for 13% of the global burden of disease, defined as premature death combined with years lived with disability. The treatment gap for mental disorders is large all over the world, that being 76 and 85% of people with severe mental disorders in low and middle-income countries receive no treatment for their mental health conditions. More than 40% of all countries worldwide have no mental health policy, and over 30% have no mental health program. So up next is a comparison of Ireland and an African country called Malawi. As you can see from the GDP per capita stats, Ireland is a much more affluent nation with a GDP per capita of nearly 55,000 in 2014, with Malawi's as low as 822. But mortality doesn't give a complete picture of the burden of disease borne by individuals in different populations. Disability-adjusted life years is a summary measure used to give an overall indication of the burden of disease. One disability-adjusted life year represents the loss of the equivalent of 1 year of full health. So here we have shown the daily for certain conditions for Ireland and Malawi as released by the World Health Organization in 2004. So what this is showing us is that in Ireland, 3.3% of people suffer due to neuropsychiatric disorders, whereas 2.4% did in Malawi. Breaking this down, we can see that 1% of people in Ireland suffered from unipolar depression and 1.8% from bipolar, compared to 0.6% and 0.25% in Malawi respectively. In Ireland, less than 0.1% suffered due to nutritional deficiencies, in contrast to 2.7% in Malawi. And in Ireland, there was only 0.3% with HIV/AIDS, but the numbers were as high as 14.4% in Malawi. Finally, infectious and parasitic infections in Ireland were only 0.15% and as high as 30.4% in Malawi. Diseases such as AIDS and parasitic infections present much more acutely and are perceived as more of an imminent threat than mental health conditions, depriving Malawi and other poorer countries of the luxury of addressing mental health. This can also be viewed within Ireland itself. The divisive public-private system leads to a massive gulf of inequality with respect to available services to those who lack the sufficient funds. People who cannot afford private healthcare do not have the luxury of accessing some of the mental health services a wealthier person would, leading to a decreased ability to address these issues. The demographics of GPs around the country further disempowers those in more deprived areas. The lack of GPs in these deprived areas decreases access to services and compounds the difficulty of addressing these issues. As with most healthcare, medication makes up a large part of the treatment of mental health. Drugs are widely available in the treatment for a number of conditions such as depression, where the most commonly used drugs are SSRIs such as fluoxetine, anxiety, which is treated with benzodiazepines, and disorders such as schizophrenia, which are treated with antipsychotics such as risperidone. The price of medications used in the treatment of mental health issues such as depression, anxiety, and schizophrenia further reinforces the idea that mental health care is a luxury. Using HSE reference prices, the gulf in accessibility to these medications is plain to see. For example, fluoxetine and risperidone are used to treat depression and schizophrenia respectively. A monthly prescription for the average doses costs between €7.20 and €7.30, these prices being less than the actual prices paid in the pharmacies. Whilst drugs used to treat common physical ailments such as amlodipine for hypertension and atorvastatin for dyslipidemia cost €2.16 and €3.64 respectively for an average monthly prescription. Funding for mental health care in Ireland in comparison to a number of other developed countries seems to be a luxury. In 2015, Ireland spent €762 million on health expenditure, making up only 5.5% of the entire healthcare budget, compared to other countries such as Britain and Canada who spent 13% on mental health in the same period. A study carried out by Hallman in 2014 served to illustrate the effects of socioeconomic class on mental health care. The study centered around three main topics. Firstly, social class, which was determined by both education and socioeconomic classification, with income being a marginal factor. Secondly, the stigma associated with mental health issues. And thirdly, mental health literacy, which refers to the knowledge and beliefs about mental disorders which aid their recognition, management, or prevention. One of the findings of the study found that women with third-level education had the lowest levels of stigma associated with mental health and the highest level of mental health literacy. Other studies have confirmed the links between education and reduction in stigma and better uptake in mental health services. In conclusion, when we consider the money that is necessary for mental health services and resources, it is fair to say that addressing mental health issues is a luxury and is not something everyone can afford.